Next, I invite Dr. Rashmin Gandhi to speak on what is new in optic neuritis. Dr. Rashmin.
Thank you so much. Thank you, Srini. Thank you, entire team, for this very kind invite and to be part of this very well-crafted symposium. Thank you, ma'am. So the reason I wanted to talk about what's new in optic neuritis is because now the ophthalmologist, we have become again the center point of management of optic neuritis, and I'll tell you how. But I would like to start with the old concept. And this was like maybe a century ago, where a British philosopher, neurologist, Walter Bailey, thought that optic nerve is like a tube which connects the eye to the brain, and through the eye it gathers all the evil spirit which goes through the brain. And optic neuritis might be a manifestation that the tube is not functioning well and evil spirit is all gathered, accumulated. And what he thought is that this evil spirit can be drawn out like a vapor from the head, and his therapy recipe for this was to say that why don't we ask the patient to comb his hair 3 or 4 times a day, which will draw the spirit out and the optic neuritis will improve. Obviously, he didn't think about a group of patients, if they develop optic neuritis, what they will do. But from there, we have come a long way. And now it has become very relevant again for us to know what are the current concepts in optic neuritis. Why is that? Because we always thought that optic neuritis is a disease of a young female, much more common in Caucasians, not so common in Africans or Asians. That generally they will have a very mild visual impairment on presentation. Retrobulbar neuritis is much more common, and they are likely to be unilateral. All this has changed now. We now know that optic neuritis, the diagnosis, it will be always been differential at any age group. They seem to be now presenting much more with a bilateral involvement and much more disc edema than we thought initially. Also, we used to be taught that MRI scan, if you do it, it's okay. If you don't do it, it's all right. It is just for prognostication for multiple sclerosis. Steroids, if patient agrees to take it, it's all right. Otherwise, at the end of 6 weeks, patient would have equal recovery even without steroids. Again, that has changed. And why that has changed? Because now we see more and more of the optic neuritis, which is because of antibody which are circulating in the blood, which are affecting various parts of the structure of optic nerve. There are 2 antibodies which are known, and more antibodies are being looked at to see why there is so much of variation in presentation of optic neuritis. The 2 diseases which are known, or 2 antibodies which are known right now, is causing neuromyelitis optica, antibody to aquaporin 4 water channels, and MOG antibodies. So why our role becomes important? Because now these patients don't complain of pain. A typical feature of optic neuritis seems to be that patient would have pain which is aggravated by eye movement. But the patient who develop optic neuritis because of these antibodies, they have less complaint of pain. They seem to be having much more disc edema than the other patients. Generally, both eyes are affected, and the vision loss is severe on presentation and may not improve so readily. The other symptoms that we should be asking for is uncontrollable vomiting and hiccups, and I'll again explain as to why these patients complain of hiccups. Is because the area of the brain which are affected in this antibody mediated optic nerve damage are different from what are traditional, described as traditional areas of the brain which are affected in patients with optic neuritis. The dorsal midbrain area, area postrema, so area around hypothalamus is affected in these patients, and that's the reason why they complain of this hiccups and vomiting. The other important reason why we should be vigilant about these is because if we alert the neurologist saying this looks like antibody mediated optic neuritis, then there is a threshold for starting plasma exchange is low nowadays, and if now large studies are still pending, awaited, but if plasma exchange is done within the first week of the attack, then there is a thought that these patients, you have saved them from paraplegia, a debilitating neurological problem. So plasma exchange, IVIG seem to be now way to go. Also, even if patients don't get plasma exchange, these patients would require one of these steroid sparing agents like azathioprine or rituximab for a longer period of time. This was all about NMO or neuromyelitis optica or Devick's disease. A similar antibody which is causing optic neuritis is MOG. Here, the MRI will show that the optic nerve has become much thicker than usual. So what it tells you is that, as I said, ONTT said, yes, if you can do MRI, great, you will be able to prognosticate. But now MRI becomes extremely important because MRI itself will give you a clue whether are you dealing with antibody-mediated optic neuritis. If you see areas like chiasm and optic tract getting affected, you know that you are dealing with NMO. If the optic nerve is thicker, what is described as perineuritis, you know that you might be dealing with MOG-related optic neuritis. So, to summarize, all patients who we think has optic neuritis now should get MRI brain in orbit with contrast with appropriate sequencing. So you should alert radiologists that you're thinking of optic neuritis. ONTT said that if you did give a treatment, it's fine. If you didn't give treatment, it's fine. Now every patient who is suspected to have optic neuritis should get steroids because you're probably now preventing or delaying the neurological damage and lower threshold of plex. Now, why we are important in all this is because it's we who will be knowing that patient has a bilateral involvement, one eye involvement might be lesser. It will be we who will know that patient has disc edema and that patient has profound visual impairment on presentation. So if we are able to alert neurologists about all this, we know that we've done a lot of good for the patient. I thank you, Srini and Dr. Amrita, once again for the kind invite.
Thank you, Dr. Rashmin. See, when the AO's National Symposium was planned, I wanted the best of the best, and undoubtedly, Dr. Rashmin Gandhi is one of the best, or maybe the best neuro-ophthalmologist in India. Thank you, Dr. Rashmin.
Thank you.